Welcome to the CBT Dive, a vodcast that goes into the lives of real people with real struggles. Each episode welcomes a new guest who wants to explore a challenging situation using the most common cognitive behavioral therapy tool, the thought record. Your host, Raheem Thawa, is a social worker and psychotherapist based in Toronto and well known for his work in LGBTQ communities. He's created the CBT Dive to demystify what therapy can look like and share intervention skills for wellness. We hope that each episode helps you along on your own journey for insight and self-compassion.
Hello, welcome to the CBT Dive. Today I have a special guest, Dr. Farooq Naeem. I'm just going to say a little bit about our guest before we start asking questions. So Dr. Farooq Naeem is a professor of psychiatry at the University of Toronto and a psychiatrist at the Center for Addiction and Mental Health. He completed a Master's of Science in Research Methods in Health and later a PhD in CBT and Culture from Southampton University in England. He also trained in psychiatry in Liverpool. Farooq pioneered techniques for culturally adapting CBT. These techniques have been used to adapt CBT in South Asia, North Africa, Middle East, Kenya, and China. His research areas include CBT, psychosis, and culture, with an overall aim to improve access to CBT. He has also published on issues related to health services and quality improvement. He works with a team of IT experts and has developed a CBT-based therapy program called eGuru that can be delivered through web and smartphone apps. Welcome, Dr. Naeem. Thank you so much for being here.
Thank you. Pleasure.
Yeah. So, Dr. Naeem, let's start with your PhD topic. It seems like early on in your career, or fairly early on, you knew you were interested in cross-cultural approaches to mental health interventions. What got you interested in that?
Thank you. I think that's a very important question because it'll allow me to share my journey or the beginning of the journey.
Please do.
You see, I was doing my senior residency training with David Kingdon, who's a pioneer in CBT for psychosis. And I was looking at data from different trials. And one thing I noticed was, and we're talking about like 2003, 4.
Mm-hmm.
And I realized that so even in cities like Manchester and Birmingham, where there's a huge number of non-white people, in these trials, there were not many non-white people. So first of all, I thought, what's going on? So first thing seemed like at the level of recruitment. And when we looked at the data a bit closer, we realized that even those who join or are recruited into the trials, they dropped out very quickly. So then I started looking at the literature and I realized that, and actually at that time, there was not a lot of literature. There was some from the US, but nothing in Europe or the global mental health. So I then became familiar with the concept that the modern therapies which are developed in Western Europe or North America, they are underpinned by different cultural values. And I kind of reflected on it and I kind of realized, really, yeah, that's true, because you see, in CBT, we have a concept of dysfunctional beliefs, right? Which I'm sure you're aware of. Now, one dysfunctional belief, for example, is dependence on others, or sacrificing your need for the needs of others. So these are some of the dysfunctional beliefs in traditional CBT, but they're not dysfunctional beliefs in many non-Western societies. They are actually you're seen in high esteem if you actually sacrifice your needs for the needs of others in many
Right.
Asian and African and rights cultures. So
Yeah.
I thought there's something missing here, and that's that's the reason I decided to do my PhD in CBT and culture.
Okay, lovely. Well, you already started talking about what I wanted to get into, which is, what are some examples of how like Western approaches to therapy or CBT in particular don't always fit with other cultures. Um, I ask this because I think some people would say, therapy altogether is Western and not for other people. But I think you and I would both agree that they can be adapted. But I guess I'm trying to figure out what is it that doesn't fit for people? What needs to
Yeah.
change?
Yes, yeah. So it's not just really the Western therapy. Mindfulness is an Eastern spiritual
Yes.
tradition, and I want to make it very clear, because especially therapists in the West or people in the West think mindfulness is some kind of psychotherapy that was invented in South Asia, which is not true. But my point is, mindfulness was adapted by the Western therapist. So adaptation of therapy is not something new, number one. Number
Right.
two, even if you look at the CBT model has been adapted over the years. So for example, if you look at the history of the CBT model, the initial model by Beck was for depression. Then
Right.
you saw adaptations for anxiety. Then CBT model was adapted for trauma,
Mm,
right? And then CBT for psychosis is also an adaptation of the original model. So adaptation is not something new,
mhm.
and in fact, my take on adaptation is that when it comes to cultural adaptation, you should not change the theoretical, or you should not touch the model,
Mhm.
but you should uh, you should modify the method of delivery to engage people from other cultures.
Okay.
So you don't change the theory. But anyway, regardless, so my point is, so adaptations of CBT or psychotherapies are not new. And I mean, even if you think about the history of Western psychotherapies, uh, therapies have uh, evolved and have been adapted. So for example, we started with behavioral therapy, then REBT comes, then it becomes a little bit more refined, becomes CBT, and then it becomes third wave therapies, which have CBT and mindfulness techniques, right? So
Right.
adaptation is not anything new. Uh, and in terms of differences between the Eastern and the Western cultures, uh, uh, there are multiple kind of differences. For example, and I can give you just one or two examples. Like one example I gave already was of dysfunctional beliefs.
Mhm.
And another example would be working with the families. The CBT, especially the Northern American CBT, is very much focused on, and it's been criticized, right? You know that the main criticism
Mhm.
of CBT was, okay, it was developed, which I don't agree or disagree. In particular, people have the right to have their opinion. Uh, but yeah, people say CBT was developed uh, for the Wall Street middle class white men. Remember,
Aha.
there is the main criticism of CBT. Um, so yes, it is underpinned by individualism. Okay,
Right.
and so what do you do when you're dealing with people who are not individualistic, who live in communities, who live in families, extended families, uh,
Right.
and the family wants to know what's going on in therapy, and that's something we teach our therapists, to not share any information, or or not to engage anyone. So you
Right.
see, these are important kind of differences. Finally, just one huge difference is the illness belief model, Now, uh, the causes of illness are biopsychosocial in the Western world,
Right.
and and in many non-Western countries, the causes of mental health problems are spiritual, and they have a
Yes.
huge spiritual component, right? So,
Yeah.
uh, so in other words, the illness belief, model, or cause and effect relationship
Mm,
are different. So the
right.
formulation that I advise in culturally adapted CBT is a biopsychosocial spiritual formulation rather than a biopsychosocial.
Right. Okay. Thank you for that. Look, as you're speaking, it's really making me think about um, my own experience with different cultural formulations of mental health or mental illness. And culturally, my community often would think about nudger, which is like a kind of evil eye, or they would talk about things like jinn possession, like a spirit
Yep,
possession.
yep.
They might also think about mental illness as a result of, not being pious enough. It's like a religious kind of repercussion, things like that. And so, what does it mean to really adapt CBT to make it culturally appropriate when, I think from a certain perspective, some of those beliefs or that etiology of mental illness would be seen as, um, I don't know, in itself delusional or in itself, like I'm seeing a bit of a conflict. So help me
Yeah.
understand, how do we adapt this model?
Um, when you say conflict, what do you mean by conflict?
Well, if I were to say, I'm struggling with depression, and I think it's because um, uh, it's the result of evil eye. I'm the target of someone else's contempt because I showed too much pride, for example.
Yeah.
uh, something like that. One might say, okay,
Okay.
this my belief itself
Yeah.
is delusional or
I
it's
got it. Yeah.
unfounded.
Yeah.
Yeah.
So you see, yeah. Um, uh, I'll just take one example and elaborate on that. And you did mention
Sure.
that, and that is uh, uh, being religious means you can't be depressed. You touched on that, something
Yes.
like that, right? Now,
Mhm.
that's a very common belief among Muslims and Jews
Yes.
because it's based in the holy books.
Mhm.
And but the exact kind of verses are, and I'll just kind of that if you are a true believer, you will not be sad.
Right.
So you see, my work, because my work took me, and I'll give you another couple of examples in a second. So there were actually time, it took me some time to uh, to explore a certain kind of belief. And I'm not going to say pathological or normal or whatever.
Mhm.
I had to explore. So in this case, I had to talk to a lot of religious scholars, both Jewish and the Muslims. And then
Mhm.
actually, they told me is that uh, the holy books actually talk about you won't be sad in the afterlife. So that's very important thing.
Ah,
Yes. Yes.
okay.
So basically, the explanation is, if you are a good believer, it makes sense, right, from religious point of view.
Mhm.
Uh, but people actually have misinterpreted that as, okay, you're going to be depressed or unhappy in this world too. So
Mm.
a lot of this work is actually helping people uh, 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 or tracing the belief or the origin of the belief and see where it's coming from. And that's why a big part I advise of the culturally adapted CBT is to work with people, say spiritual and faith healers, so to understand the spiritual part of the origin of uh, a certain mental health problem that a person believes in. right?
Mm.
Uh, uh, and when you present this, excuse me, explanation to many patients, they're absolutely fine. And it makes sense to them. They say, okay, oh, that's what it means. So that is about,
Right.
that's a very important part. So you see, some investigation, working with people from that kind of background who can explain these beliefs to you as a therapist, so you can explain to the patient. And there are other examples. So, for example, in my work, when I compare the differences between, I'll take this one group, South Asians in England, and because most work on South Asians comes from England.
Right.
Unfortunately, North America does not have a lot of research work on South
Mhm.
Asians. Don't really, I was a bit surprised when I moved to Canada a few years ago to see that even though South Asians are the biggest minority in this country, and yet there's not any research on mental health of South Asians or generally health of South Asians. Anyway, so one example was when you compare. So we were comparing the results, and one thing was noticed, like, was um, uh, biological, psychological, social, and then there was some kind of very cultural kind of beliefs, and it took me some time to explore where they're coming
Mhm.
from. For example, one is uh, phlegm, increased phlegm in the body. So
Okay.
can be a cause for mental health problems. So, so I had to explore, so I had to look, and I asked people, and I obviously look at the literature and everything. And then it turns out this is actually um, a Greek concept, old Greek medicine concept.
Okay.
And then I'll tell you where it came from. How did it end up in South Asia right?
Okay.
Uh, 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 the second example is as one person, not one, but many people believe that increased heat in the liver can cause mental health problems. So again,
Ah.
it took me some time, and I looked, I explored, and then I found this belief comes from the old Chinese medicine: eat cold, different organs of that.
Right. Right.
Uh, Third example, some people said the uh, 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 masturbation can cause mental health problems. So then again, I had to explore. Then I realized that it's actually a belief that comes from Ayurveda, the Indian medicine. So,
Oh.
so yeah. Uh, uh, so you see, okay, and my understanding is because you see, like Greek medicine in the old time, that was the most kind of advanced medicine, like the current Western medicine is these days, right? And then
Right.
plus also, especially South Asia and South Asia, there's so many invaders, and they all came through there. And when they came with their medicines, with their doctors, right? Old time. I
Right.
think of the old times, armies used to travel with the physicians, and it was very slow kind.
I see.
So that's where these beliefs are kind of, that's how they travel. So you can see there are some really interesting kind of beliefs when you're dealing with this population, and the way to deal with that and obviously you can't change that, because if your father has told you that your depression is because of phlegm in your body, then you're less likely to change that view until unless I present some solid evidence for you, number one. Number two, if the belief is really, really strong, and it's not kind of, but okay, important thing to keep in mind: people in the uh, in the non-Western cultures also have a, a multi-component model of mental illness. That's a very important thing, and it's a good thing, because you see, if somebody is saying, Okay, yes, there are biological causes. Genetic causes are very common among South Asians and Asians, and it was a bit shocking for me when I realized this for the first time. You know, you might be aware that many South Asians hide mental health problems in the family because of the impact it can have uh, on arranged marriages, uh,
Right.
because
Yes.
the concept of the genetic transmission of disease is actually very strong in these cultures. It is shocking,
Mm,
isn't it? You wouldn't think that, right? Okay, that they'll have such strong belief in genetics, but yeah. So the whole belief, how hiding, there are multiple causes. Obviously, the genetic component is very, very strong. So,
mm.
so it's about modifying the beliefs, providing education, but also because it's multi-component, so you don't necessarily always need to fight against one belief when you know the person believes that it's a multifactorial kind of causation.
Okay. So if I'm hearing this right, um, when we think about beliefs about the cause of illness, phlegm, um, masturbation, these kinds of things, uh, it wouldn't be the clinician's job to change those beliefs necessarily, but just to be aware of them.
Aware
Is
of.
that right?
Yep, yep, yep.
Okay.
And
Okay.
you see, very often you can educate patients. So
Mm,
it's not like your religious belief that's so fixed that they wouldn't
right.
change. So you can always educate them, and if you feel that that's kind of they're not changing, then then if the person has a they use by psychosocial factors anyway, so you can work on
Mm,
you can still work with the patients. That's my point.
okay. Um, Here's my question. Have you, so in the research you've done, um, what have the outcomes been in delivering CBT interventions to people in different countries and different cultures? So specifically, I think you've done studies in Pakistan with South Asian Muslims, but feel free to draw on any study. I'm just
Yeah,
interested to see what the uptake and outcomes are like. Because when we
yeah,
talk about a North American study, or a study in the UK, we're saying that there's a high attrition of South Asians or they're not well represented. So when we go to a South Asian context, what does the intervention look like? What are the outcomes?
yeah. So uh, um, the outcomes in general of culturally adapted interventions are better than the standard CBT.
Wow.
Yeah, yeah. Uh, However, this is just still a very kind of new field, and
Mhm.
there are not many RCTs. There are not many fully um, powered RCTs. Uh, um, so the jury is still out.
Okay.
you know
Okay.
yeah, but the existing evidence actually indicates that people are more um, uh, likely to uh, benefit from culturally adapted CBT. And it makes kind of sense, really, even if you don't think about, because the basic concept in CBT is to provide an individualized therapy, right?
Right.
Even if you don't think about the evidence from the research, it is the duty of every therapist to think
Mhm.
about uh, client's culture. Isn't it right? That's what we teach. That's what we train our therapists.
Mhm. Dr. Naeem, I'm really interested in talking a bit further about your work around CBT for schizophrenia and psychosis. I know a lot of clinicians who struggle with clients who have psychotic symptoms, have been, are on antipsychotic medication, some are functioning very well, and others bring out a lot of hopelessness in their clinicians. And so I think there's sometimes this idea that people with schizophrenia are very difficult to treat. Can you tell me a bit about what CBT for psychosis or schizophrenia looks like, and perhaps what's the goal of
Yeah.
CBT with people living with schizophrenia?
Yeah. Thank you. Now, CBT for psychosis is a British kind of adaptation. So it's not as popular in North America as it should be. And most of the RCTs come from Europe.
Okay.
And the last time I looked, I think more than 40, 50 randomized controlled trials have been conducted, and the evidence overwhelmingly indicates towards the effectiveness of CBT for psychosis in reducing delusions, hallucinations, even negative symptoms.
Oh,
So, yes, so the overall aim is to help the person to become more aware of the symptoms, to help them develop some insight, some self-awareness, and reduce the distress, reduce the intensity of the symptoms, and 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 uh, and therefore improve the quality of life of patients.
okay.
The main kind of techniques we use for delusions, we use Socratic dialogue,
Right.
and uh, uh, and for hallucinations, coping skills, but also reattribution techniques, challenging the voices, or teaching patients to challenge the voices. Negative symptoms, for negative symptoms, we use behavioral activation. So all these kind of things are used, and but yeah, the overall idea is to reduce distress and improve quality of life. And there's plenty of evidence that you
Okay. Um, so it makes me wonder a bit about like this idea of adaptation and learning more about different cultures, adapting um, the original model for different kinds of illnesses. Do you adapt the medium of therapy as well? I've read, like in some of your work, you've talked
Yeah.
about doing CBT interventions by email. Can you tell me a bit about that?
Yes.
How does
Yes.
that work? How do you structure that
Yeah.
work?
So that's really something I realized 7, 8 years ago, and it was mainly, and by that time I had conducted a few RCTs. I knew adaptive CBT works, but then I actually realized doesn't matter how much I adapt CBT, the issue is of access.
Right.
Because, right, forget about adaptive CBT. We don't have CBT therapists or sufficient number of therapists to provide therapy to the general population in general. So that's when I became more interested in improving access to therapy, and not just for the uh, um, refugees or immigrants kind of population, but for everyone. And then another thing, that's around about the same time I started noticing that internet is very cheap in many low middle income countries. Okay, mobile phones are very. So you, for $50, you can buy a high quality smartphone in India and Pakistan and Sri Lanka, right? So these kind of countries, you can buy a very cheap mobile. So that's the kind of time I also realized that this is the only kind of way that we can improve access to CBT.
I see.
So that's why I took that direction. And so eGuru, which was a set of CBT apps, I stopped working on that when I moved to Toronto 4 years ago. I was in Queens before that for 3 years.
Uh-huh.
And because I got busy, but now I've started working on eGuru apps again. But also, you see, recently, actually, we published the very first online culturally adapted CBT. It's a pilot kind of evaluation, and
Okay.
we conducted that, and that's the first culturally adapted online CBT program published from South Asia. And it was actually happened yesterday. And we
Wow.
found that people
Congratulations.
engaged, yes, thank you. And people engage, with therapy, and the results were fantastic.
Mm.
So you see, it seems like, and the other thing also we need to keep in mind in global mental health, poor countries are becoming richer, people are becoming more educated, and in addition to improved access to digital technology. So all these factors, mean, we should focus on using apps and web apps to deliver therapy. So
Okay.
that was the whole idea behind.
All right. That's very interesting. Are there any populations or um, conditions for which CBT should not be conducted electronically, like by email or by using an app?
Uh, so Manai, I don't know the exact kind of answer to your question, because
Okay.
there's not a lot of research in this area. You see, this is
Right.
a very new area. Uh, However, the exclusion criteria most randomized controlled trials have used are kind of straightforward. So, for example, having access to technology is number one. Number two
Yeah.
is digital literacy. So, digital literacy is very important. Uh, and third is not having any intellectual disability, right?
I see.
So,
Okay.
so these are the very basic kind of requirements for digital mental health or delivery of CBT through digital technology.
Mm. Now, you have this particular interest in working, doing CBT for psychosis, and I just wonder, would that be appropriate to do by email? I worry that people with psychosis sometimes may have a tough time using technology to
Yeah,
be vulnerable.
not not necessarily.
Okay.
It depends on the stage of illness, or depends on the age of the patient. Many
Mhm.
people actually, you see, one thing we need to keep in mind is modern medication has helped a lot. We have this concept that people, and it's true. Until 10, 15 years ago, a lot of patients used to have cognitive deficits, which is part of the normal kind of illness process. So chronic
Yes.
schizophrenia and cognitive deficits, they go together. And it still happens, unfortunately. With the modern medication, improved compliance, I see that is becoming less and less of a problem. So while we still struggle, and while we still have a reasonable number of patients who are treatment resistant,
Mhm.
uh, the important thing to keep in mind is that uh, they are uh, uh, there are majority of our patients, they actually can engage. Having said that, I think there are one or two trials of CBT, online CBT, but that's actually face to face through Zoom or WebEx for schizophrenia, and also some kind of websites with mixed results. But generally, this has not been used a lot in people with schizophrenia. One area where some progress has been made is use of virtual reality programs to reduce fear and phobias in general, but also in people with schizophrenia. So
Oh,
yeah,
that's fascinating. The virtual reality programming. Okay. Well, we've been talking a bit about schizophrenia, and I want to ask um, what your stance has been on that diagnostic label in the clinical and academic community. I think there's been some debate on whether or not it's a helpful label, whether the stigma makes it. Um, I don't know whether the
yeah, yeah,
stigma
yeah.
itself is too
No,
much of
no.
a barrier. So I wonder what is your stance? Should it be renamed?
Right.
What's its utility?
Yes. No. I actually, when I was actually very much in favor of changing the name of schizophrenia, and I and my group, we wrote some letters and articles as well 15 years ago. But you see, then I actually, but I don't think it's going to make any change if you change the name.
Uh-huh. Okay.
And the reason is because I learn, and because of my work, actually, I started thinking more about the cultural sort of factors, and and it gave me, you see, it gave me multiple insights working in many low middle income countries. Um, so, for example, I learned that people believe that epilepsy was because of uh, evil spirits
Huh. Okay.
in many, many, many low middle income countries, especially the Middle Eastern and the South Asian. I don't know about other cultures, these two.
Okay.
And you see what happened then. So this is like 30 years ago, 40 years ago, people tell me, my colleagues in the field. And then they say, as the anti-epileptics became available, and people could afford the medication, and it became obvious that epilepsy can be treated with the help of medication. Now hardly anyone believes that this is because of evil spirits,
Hmm.
right? For me, it was a big lesson. The reason was it was big lesson was because it showed you can't change people's minds or their concepts or their uh, uh, concepts or even misconceptions about an illness. And this, I think, also includes stigma. To be honest with you, until unless you change the outcome, right? I mean, if you look at the history of mental health problems, wasn't there a time when people with schizophrenia were burned in Europe because
Hmm.
people thought they are witches, or right?
Right.
So it's not really that changing a name is going to make any difference, and even just psychoeducation alone is not going to make a difference. I
Hmm.
now believe that until unless we change the outcomes of schizophrenia,
Yeah.
I don't think just changing the name is going to make.
Okay. Um, to that end, do you think, and this we're getting towards the end, so I hope I'm not tiring you
Yeah, that's
out.
fine. That's fine.
um, I've heard some people argue that what we call symptoms of psychosis um, can be explained better through other cultural lenses, and so shouldn't be in the category of psychosis. So, for example, um, after a loved one dies, lots of people report that they will get they like that loved one will show up in their dream, and somebody would be
Yep.
inclined to call that a visit, and they would see it as something affirming. But if we stick to a certain kind of model, we might call that we might say that it's normative, but we might also call it a kind of psychosis. And I wonder how,
Yeah,
if that language could be challenged a bit. What are your thoughts on that?
I I think any clinician who does that is a terrible clinician.
Any
I'm
clinician
serious
who,
about. I've seen this happening.
yeah,
Seen this happening. People being diagnosed with schizophrenia because they had a trauma. They see things at night in the dark, etc., uh, and or other kind of visions, and being diagnosed, or someone who hears the kind of voice of a dead relative or things like that.
yes.
Uh, so somebody a clinician who diagnoses this kind of picture, uh, you see, schizophrenia people should be careful with diagnosing
Hmm.
schizophrenia, because you are giving someone a lifelong label.
Right.
And uh, uh, and we need to be careful with this kind of experiences, which are mainly expressions of distress. I mean, you can even talk about the religious or spiritual experiences people see or hear things, during the
Hmm.
religious experiences. Uh, but the distinction between schizophrenia and this kind of experiences is that of duration, uh, and then the exclusion, and most importantly, it's also about uh, being being careful in judging the symptom.
Hmm.
For schizophrenia, diagnosis of schizophrenia, we first have to think about the duration criteria. The symptoms should be there for 6 months.
Yeah.
Number two is, the collection of symptoms. So generally we have, and this is like every disorder in DSM-5. Uh, Number three is exclusion. That person shouldn't be using, drugs, alcohol, stimulants, that kind of stuff. My
Uh-huh.
point is, uh, 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 many psychiatrists unfortunately do not think about these general criteria when they diagnose someone. And the biggest example is I see so many patients, being misdiagnosed with bipolar. And when I actually ask them, they say they had mood swings, but the mood swing was never more than a day or two. Now,
Mhm.
in order to diagnose bipolar, the person should have experienced manic episode for at least 1 week, right? So
Right.
my point is, I think that's more a kind of problem misdiagnosis, because the
Mm.
modern DSM, ICD-11 systems are fairly kind of advanced, and if psychiatrists use them carefully, they shouldn't be misdiagnosing people. But the
Right.
simple answer is that's a terrible thing, if it's happening even in this day and age.
Yes. Um, Dr. Naeem, my last question, if clinicians want to get training in being not just culturally competent, but being able to deliver culturally adapted CBT for specific communities and populations, how might they get that training?
Yeah. So in Canada, I'm currently leading a large randomized controlled trial, and it was actually mixed study, but currently we are on the RCT phase.
Mhm.
And we are running the trial in Vancouver, Toronto, and Ottawa. Uh,
Okay.
and at the end of this RCT phase, we'll develop a training specifically for the trial is for South Asians here, and we'll develop the training package, and that will be available freely. Uh, so just
Look out for
something
that.
you, yes, yes,
Okay, lovely. Thank you so much, Dr. Naeem,
my pleasure.
for being with us. And when I'm back in Toronto, maybe our paths will cross again.
Absolutely lovely. You take care. It was a pleasure talking with you.
You
Thank you.
as
Bye bye.
well.
Bye bye.
Thanks for tuning in to the CBT Dive. Don't miss an episode. Subscribe to our YouTube channel at thecbtdive.ca. You can also listen on the go, wherever you get your podcasts. To follow Raheem on social media, check out ladyativan.com. See you soon.